Good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Mark Jeffrey, Chair of the panel. So first of all, some housekeeping information. If there's a continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at Queen Victoria statue in Guildhall Square. In order to comply with the Guildhall Trust fire marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. So this meeting, could I just draw everyone's attention to this meeting's being web streamed live. Everyone speaking via microphone will be on camera. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphones and remember to switch them off when they have finished. So could we have introductions around the table? I'm going to start from my left. So if you could say your name and the organisation that you represent or you work for, please.
Yeah. Hi, I'm Denise Perry. I'm a Liberal Democrat councillor for St Jude Ward.
Okay. I'm Antonia Harrison, Havant Borough Council, Cabinet Lead for Communities.
Councillor Susie Horton from Portsmouth City Council.
Councillor Vivian Atchell from Winchester City Council.
Toby, do you want to say who you are?
Toby Payne, Local Democracy Reporting Service. I'm here because the press desk is too far away from the plug.
Councillor Joe Standen, Reform Councillor for Paulsgrove Ward.
Councillor Graham Heaney, Labour Councillor for St Jude Ward in Portsmouth.
Councillor Robbie Beach, Conservative Councillor for Anglesey Ward and Gosport.
Lisa Gallagher from Democratic Services.
And for the record, I'm Councillor Mark Jeffrey, Lib Dem for St Thomas Ward, Portsmouth City Council, and Chair of HOSP. So going straight on to, just to let everyone know at the meeting, members will have read the report, so presenters, please just highlight any developments that have occurred since the publication, and then we'll go around and probably ask questions to the report. So I've got apologies from Councillor Leslie Minion from Gosport Council, but I think she represents Hampshire County Council. And we've also had apologies from Tracy Redmond from the South Central Ambulance Service because of the pressure of the work today. She's not able to attend. So what I'm suggesting is that if we've got any questions, we can, well, I'll let you decide. Do you want to ask questions online outside of this meeting, or would you like to invite Tracy back to the next meeting in September? Does anyone have any strong views either way?
Maybe if we've got a question, just ask it online.
Everyone okay with that? Yeah, so we'll do that then. So thank you for that. So I guess we still note the report, don't we? Even though we're not asking questions. So I'd like to formally note the report that we've read it. So okay, so just going through declarations of interest. Does anyone have any declarations of interest? That's a no. Okay, and then agenda.
Sorry, Chair. I'm not sure if I'm meant to. I'm a public elected governor for Hampshire and Isle of Wight Healthcare Foundation Trust. I don't know if that's a declaration. Yeah.
I think it is, but you can check, aren't you, Lisa?
I'm the National Clinical and Operational Manager for PHL, which provides out-of-hours medical services on behalf of SCAS.
Noted, thank you. Any other declarations of interest?
I don't have a declaration, but I do have a question. We have a vacancy on the membership. Where is that from, if I may ask?
It's from Havant Borough Council, yeah.
That doesn't make sense, does it?
Sorry, apologies, Fareham Borough Council, sorry.
So just for the record, the areas that the Health Overview Scrutiny panel covers for this panel is for the QA area. So there are different hosps for different hospital areas. So, so the representatives here are from different councils around those areas. Okay, so agenda item 3 is minutes of the previous meeting. So if I go through the pages, if anyone has any spots any sort of errors or anything that needs clarifying, can you raise your or press your button? So agenda item 3. So going through what is marked as page 3, page 4, 5. 6, 7, 8, 9. So that's all. So in order to agree the minutes, would someone formally propose to agree the minutes, Councillor Horton?
I'm happy to formally propose the minutes as accurate.
And I was at the meeting as well, so I'm happy to second that. Thank you. Okay, so going straight on to, I've mentioned that agenda item 4, Tracy Redmond can't be present, so we've noted that report. So agenda item 5 is adult care update. So would you like to both come forward? And I know Andy and Debbie, but if you could introduce yourselves and your titles, that would be really helpful. And then if you want to give a very brief summary, Andy, that might be helpful as well. Thank you.
Good afternoon, panel. My name's Andy Biddle. I'm the Director of Adult Social Care at Portsmouth City Council.
Hello, so I'm Debbie Young, Assistant Director of Commissioning, Quality, Contracts and Performance for Adult Services.
Debbie has a much better title than I. So I'll just give you a brief summary of the report. I'll take it that you've read it and then, as Chair requests, and then we can move on to questions. So this is the regular 6-monthly report that Adult Social Care bring for this panel. We obviously appear in between times when there's a particular item of interest, but in this case, this is the regular report. It's there to provide an update on key adult social care activity running from November of last year to up until the beginning of this month. We're asking you to note the report. There's no decisions required from it. And what we've tried to do probably for the last 2.5 to 3 years, I think, is focus on the impact for Portsmouth residents. There's always a lot of words in these reports, some of them fancy, some of them not. There's always a lot of talk about strategy and that kind of thing. But what we've tried to do is link anything that we've spoken about into what does that mean for our residents. And we've tried to keep it in as plain an English format as possible. So hopefully that's reflected for you. So in section 4, we've talked about more of the national picture and some of the policy changes and legislative context for adult social care recently. Our ICB colleagues have been through quite a significant restructure, which we believe is now completed, but it is probably the second or third restructure that we've seen since they came into creation, and it's been quite disruptive for them, and we don't underestimate how difficult that's been. Just to comment really that we've maintained some really good relationships during that. We've kept up with our regular interaction with them. We've got a great partnerships director in Portsmouth, Bernie Allen. Whereas when the ICB was created, we had some problems in maintaining those relationships because we work in a very integrated way. Here we think we've managed to sustain them throughout this period of change for them. We've also seen the proposal for reforms for children with special educational needs. I'm sure you'll have heard that in different environments. Whilst that's not directly impacting on adult social care at the moment, we do of course work with younger people in transition. So that when we do see those SEND reforms come into effect after the consultation, we'd anticipate there'll be some kind of effect for us. We've talked about the CQC framework. CQC began to inspect councils under their Care Act responsibilities from about 2024. Yes, it was, wasn't it? December 24. Hard to remember. They've now completed their baseline inspection, so they've inspected every council with adult social care responsibility. And they've moved on to a different framework where it's much more akin to Ofsted. There'll be regular annual conversations with adult social care departments, and they'll choose as to whether they do a full inspection, which then changes the rating, or they do something like a themed or focused inspection, which may be on as it suggests, a particular theme or focus, which wouldn't change the rating. That next tranche of inspections, we believe, has started at the end of May of this year. Our visit was in October of 2025. So we don't anticipate a visit at this moment in time, but we will get about 6 weeks' notice if we do have another. We talked about the Supreme Court judgment. This was a couple of weeks ago. This is really significant for adult social care. It's related to something called the Deprivation of Liberty Safeguards, and there was a judgment involving Lady Hale, the previous president of the Supreme Court, in 2014, which essentially said that most people living in care homes that would be seen as not able to make a capacitous decision about where they lived would be subject to these safeguards. So an assessment had to be made, a visit had to be made, several assessments had to be made, and then that had to be authorised. The judgment a couple of weeks ago overturned all of that. The Supreme Court unusually said it got it wrong in 2014. Given it was only 2 or 3 weeks ago, we're working through that at the moment to understand the implications. We anticipate we'll have less assessments and less referrals coming in, and there'll be less people deprived of their liberty. But it's a little early to say that at the moment, so we're still working with that change in regime. We've talked about the Supported Housing Act. That will provide, is supposed to provide more support for people that are receiving support as well as housing through housing benefit usually. Again, that will play out. That's been given royal assent, but it hasn't arrived with us yet, so we're doing a lot of planning around that. We've then talked about our strategy and improvement plan. We've listed our 6 outcomes and talked about our improvement plan, which is grouped into 7 activity areas to achieve those outcomes. We've been working on that plan probably for the last 2 years or so, and we update it every 6 months, 12 months or so, and it's about us saying there are ways that we could improve, there are things that we could do better, we understand them, we've seen that from data and feedback, and so we add that to the plan and work on it, and we also share that with CQC when they visit us. We've then gone in to talk about our activity under that plan. I won't go into lots of detail, but our main objectives are to prevent, reduce and delay the need for care, to keep people as independent as possible in their own homes, to ensure that however we worked, it's based on a strength-based methodology, understanding what people can do for themselves and how we can help them to stay independent, and co-production, so that we're hearing from people how they want their services organised and managed and run. We've talked about statutory process and pathways. We've talked about a major redesign of how we work in terms of safeguarding. Really, really important for those of our residents who may not be able to protect themselves from others, or may not be able to protect themselves from themselves, if you like. And we're undertaking that redesign at the moment. So we started it probably in December of last year, and we don't anticipate it'll be complete for the next year or so. So it's quite a significant piece of work. We've talked about our work with the provider market in Portsmouth. We've got a very close relationship with most of our providers, given it's quite a small, compact city. And we are introducing new quality standards with our providers and looking at new contracts for extra care. We've implemented a new contract for extra care in the last 12 months, and thinking about how we work with people around quality and understanding the quality of the care that people receive in the community. We've talked about our workforce, our ambition around digital, and inevitably our finance budgets and savings. We've then gone on to some key developments around working with our day services we have in Portsmouth and purchasing of a new case management system. For any of you that have ever been involved in implementing new IT systems, I'm sure you'll understand it's a complex, intense and painful piece of work, and we are at the moment almost at the point of going out for procurement for that system. We've talked about our governance, so we've started an external improvement board because we don't want to continually mark our own homework, so we have someone called a partner in care and health advisor who works in the region, who is independent of the council, who chairs that. Our chief exec sits on that board and our cabinet member sits on that board. And every 2 months we report to them on our improvement plan. We've done some, given some detail on our internal governance and talked about auditing and standards. We've given a few challenges and risks, and then we've talked about what we're intending to bring to you in our next report. Hopefully that's a reasonable summary, and I apologise that I appear to be melting in this particular room, but hopefully that gives you a reasonable summary of the report. Happy to take any questions.
Andy, thank you very much. It is a really comprehensive report. Before we go to questions, can I just check, are you going to provide a verbal update on the diagnostic services in Havant, either of you? No.
I wasn't planning to.
Okay. I'm not sure why it's here, but it does say, I also believe you are going to give a verbal update. So we'll pick that up at another meeting. Okay. So members, do you have any questions following the report and Andy's sort of summary there? Councillor Heaney?
Yeah, I have some questions on different aspects of the report, so I'll take the first one. I'll go through it sort of logically page by page from the front to the back. I was particularly interested in page, well, it's page 22 of the big report, but page 7 of your report, and it talks about the issue of direct payments. You talk in the paragraph about the problems with direct payments not being about individual processes or particularly people not doing things correctly. You're saying it's much more fundamental. So I was just wondering if you could say a bit about what is likely to change and what's going to be the impact on those who currently have access to direct payments, or will be wanting to continue to use the system until or unless, you know, changes happen. So what's going to happen there?
I think, so it's, for me, I think it was a cultural issue. I don't think we had direct payments as a method of delivery of care culturally embedded in our practice. And I think that because there was a financial element to it and it could become complicated to translate needs into self-purchase services, that our practitioners were quite nervous about using direct payments. I think we also had a deficit in what you could buy with them. There's not a lot of point giving someone a bit of cash and saying there's the shop when there's nothing in the shop window, is the analogy that we use. And so often direct payments can be really useful when you're working with smaller providers. An example of that is someone I met yesterday, actually, who provides healthy living support and nutritional support to 5 people in Portsmouth. Most of our providers will be providing to hundreds of people in Portsmouth. So it's that sort of differential. So we needed to develop a micro provider, which is how we term them. We needed to develop a micro provider market. So we've got someone helping us with that who his own mum has benefited from direct payments. He's had direct experience of that. He's also worked in the sector. So he's helping us to develop a micro provider market in Portsmouth, along with our voluntary and community sector colleagues through the Hive, so that we've got an offer for people when they do have a direct payment in what they need to buy, or in what they can buy, sorry. We've also done quite a lot of work in terms of learning and development with our staff around direct payments, and that's also included working with our finance staff. There's an obvious nervousness around handing cash over from the council to individuals and trusting that they'll buy the right level of care. Now, we've got sufficient checks and balances in place, but it's revisiting those and ensuring we're all confident with them. So that's probably the main bits of what we're trying to do.
Graham, do you have any follow-ups on that?
No follow-up on that. It's just some clarification about exactly what that was about.
Okay. Councillor Perry?
Yeah, I've got 3 different questions, so sorry. No, I'm not sorry at all, actually. Okay, my first question's about page 10 and to do with the engagement with providers and other stakeholders. And it's really sort of there's 2 elements to it. One, is there a timeline to when this, the delegated healthcare tasks are sort of sorted out? And at the moment, I think it's brilliant how we work together, but I'm concerned that potentially adult social care staff could be doing tasks that are medical, which is what you say in the report. So the question is, are adult social care staff at risk from a professional point of view? And also, are patients at risk? So, for example, if wound dressing is performed by a non-medical person, how are you mitigating that while you work on this? And how long do you think you might be able to get to the end of it, as in sorting it out?
I don't know, is the honest answer to the time frame. I think we're inching forward with it. We've had discussions about delegated health tasks nationally for a good couple of years now, I would say, because there's been a process whereby our domiciliary carers have taken on more and more and more as health services have changed. I think it's a good thing that we're identifying that, because we're saying, yes, there were some risks in that. There were some risks both for those staff members and for those residents potentially. So where I'm just thinking of the example we've talked about, where we identified that there were carers in one of our extra care schemes that we felt were doing quite complex tasks that they weren't funded to do and they weren't commissioned to do. We stopped that. And so I think the bit that we have to do now is to ensure that our NHS colleagues are able to sign off on those kind of tasks. They are able to initially assess that those carers are able to perform those tasks and review where that's necessary. And we're not there yet. That's the thing that's going to take the time. We've also had discussions with our providers when we've discovered incidences of what we consider to be unassessed delegated healthcare tasks being performed by carers. And we've said to them, this isn't okay, this does put you at risk, this does put carers at risk. Well, you think you're being helpful, and you are being helpful because you're working with that individual resident in the way that you should. We've still got to do the checks and balances between ourselves as health and social care. So those conversations with our providers have happened. So what we hope, I can't guarantee it, but what we'd hope is that our providers would come to us and saying, we're being asked to do this, we're not confident based on what you've said, and therefore we need to have a discussion about it. So we should be able to put in place, I would hope within the next 12 months, I may be being optimistic, some kind of way of working within the city that ensures that if there is a healthcare task that is delegated, it's done with all those checks, balances and safeguards. Please do.
Yeah, so just to follow on, so there is a national framework that Skills for Care have created. So Skills for Care are like lead on adult social care workforce. So there is something there for providers to refer to in terms of actually you shouldn't take these tasks on unless you're confident that the member of staff has the skills to actually deliver that. So that is one kind of safeguard. I think the other positive thing for us is that the ICB are willing to work with us. So I was on a partnership meeting last week, which also included Hampshire County Council. So it looks like we'll be coming together to do a piece of work, so it should be consistent across the patch. So residents across the piece will obviously have a common understanding of it. And I think the final thing to say is actually it can be a positive thing. So as you've picked up, as long as the safeguards are there, you know, if an individual can have like a team of carers coming in or an individual coming in to do a number of things for them rather than a multitude of people coming, it's a really good thing. And on an interim basis, as Andy said, we are picking these things up, but obviously it's about knowing how many of these things are going on so we can make sure we actually understand the sort of the breadth of it really, and then we get, how should I say, we've got an operationalised way of overseeing and managing it across the city, which we don't currently have.
Denise, do you have a follow-up on that particular question? Because if
No.
is your question connected with this? So, Councillor Beach.
You say about these standards and the providers will provide these standards. What levels of assurance have you got that them providers are doing the right diligence and having staff trained, say, to an MVQ 2, 3 or a care certificate level? So it's not just someone who has come off the street and will do these tasks. There's actually some substance behind it to say they've had training in order to do this.
So, I mean, that is part of the challenge. So, in terms of the responsibility, if it's a healthcare task, the responsibility remains with health. So, although social services are aware of it, we can't be responsible. What we can do is, obviously, through our quality reviews, we do undertake sample checks of training, etc. And, of course, CQC as a regulator, that is their role. So, I guess that's the other thing I should have said. Skills for Care and CQC are also going to work on this piece of work with us. They've already agreed, the regional representatives have agreed to do that with us. But, you know, the regulator go in, they undertake those checks, and, you know, it's down to the provider to ensure that obviously those individuals are skilled and trained. And as I say, when we do our quality reviews, and of course we're actually developing a quality framework at the moment, so we will be more robust around those things if we don't feel we are currently.
Stuff like wound dressings, you know, changing catheters and all that, I get is a healthcare responsibility, but giving someone personal care, washing and that sort of thing, which isn't technically a health thing, how do you know that they're able to do that in a dignified and correct way?
So as I said, so we do go in and do contract reviews. Also, we have our individual practitioners, social workers who go and do assessments and reviews. So they work with the provider, so they actually observe and they get feedback from the individuals. We will do spot checks, so we will check training records. We will look to see rota, so not only will we see that there's a certificate on file, but we'll actually look to see sort of, you know, what the planned training is as well. I think the challenge is for us, obviously, you know, we're looking at what we can see, we do observe practice as well, and really it is kind of, I say a whole system effort. We're that bit, obviously we've got CQC, but we are fortunate that there is a care homes team funded by the ICB, so they're regularly into care homes, so they also see things. We have, in terms of governance, there's a monthly quality meeting which I chair, so that care homes team, CQC, practitioners, quality contracts, they're all at that meeting, so we gather soft intelligence. So if there are concerns around something that's happened, competency, that's something that we can pick up through that meeting. So there is a way of sort of triaging that, and then what we do is we basically assign the most appropriate organisation to then go in and do those reviews, and that could be at either a service level or an individual customer level, and we would look at all those things around that individual in turn, including those people that are working with that person.
Okay, next question from Councillor Perry.
Thank you. Yeah. So page 11 to do with the safeguarding arrangement. So I think it's really good that you're changing to an electronic referral forms for professionals and members of the public. My question is, and I presume the answer is yes to this, but are you going to promote it if the start date is the 1st of July?
So it's we're using both the Portsmouth Safeguarding Adult Board website and our own website. We've also done some direct mailings out and communication. We've done a verbal update through the last formal meeting of the Safeguarding Adult Board. We've talked to providers. We think we've covered most bases. I mean, inevitably we won't have done, but we've also got the standard ASC help desk number, so which anyone can phone, anyone can get through on, and that's widely advertised. So we think we've covered off the bases. If you discover any, do let us know, but we think so.
Sorry, and follow up. So will you be emailing councillors a bit nearer the time? Because obviously we do sometimes have safeguarding issues raised in our direction.
We can do. Normally, any elected member would come through myself or my PA for any queries they've got, and we'd then direct it appropriately. But we can certainly let you have that information. That's not a problem.
Councillor Beach.
Sorry. With safeguarding, we may be referring people in for safeguarding and all that, but what is evident when I've done it previously in my other role, we don't get any resolution, you don't get any knowledge of what's happened, whether it's been, you know, looked into or anything like that. Is there any way that information about closure of the loop can be disseminated back?
Yeah, so one of the standards that we're setting for this new setup, if you like, this different way of doing the safeguarding, is that everyone will get a contact back. We've been relatively successful with contacting most folks, and my apologies if that hasn't happened. I mean, if you've got anything outstanding, refer it to me and I'll pick it up.
We raise about 60 each month, and I think I've had one back.
I will look into that. That's PHL, isn't it?
Yeah.
I'll look into that.
Councillor Heaney, did you have a question on this question?
No, I had more than one question on the report, actually.
Okay,
Yeah.
okay. So any more on this particular one? No. So I've got Councillor Perry, then Councillor Heaney next.
Yeah, my last question. So first of all, I want to say it's on page 15 about the community connectors. Having had experience of community connectors, I think they're brilliant, and I think it's something that I think we should fight to keep as long as we possibly can. And I understand it's not all permanent funding. So I sort of wanted to say that first, but also I'm interested in the sort of the additional 18 months pilot scheme to support the substance misuse recovery. And I've just wondered how that's going to connect with, because as a city we've got quite a lot of things happening to support substance misuse, both council and charity organisations. So how do you see that? And it might be interesting that you come back and report on this. How do you see that sort of fitting into our existing things to enhance it rather than to duplicate?
Yeah, we were really pleased to get that role, really, whilst we've only got it for 18 months at the moment. The community connector way of working, as you reflect, actually has been fantastic. It's been something that punches well above its weight. We've seen wellbeing outcomes for some of our residents without the aid of care or indeed medication or any other kind of clinical intervention, where it literally has transformed their lives. It's amazing, and that's down to the quality of the people doing it, has to be said. So we were really pleased to get the recovery post. What's happened in the past is that once we've got the individual in post, we give them all of the contacts that they need, and they start to embed themselves within that community, if you like. So that's what will happen with recovery. As you'll know, a lot of our residents who are homeless also have substance issues. We've got quite significant peer-led recovery in Portsmouth, both in the mental health sphere and that sort of crosses over into substance use as well. So we're going to ensure they're connected to that community of practice and establish themselves there. So we shouldn't see any duplication. It tends to take, with the community connector in the hospital, took about 12 months to start really bearing fruit, to start seeing real results, and that's what we anticipate. It usually takes about 12 months to establish, to understand the level of need and demand, some of the solutions that people are coming up with, and most importantly, the outcomes for them. And we do, I think it's a quarterly report we see about all of our community connectors with the stats and case studies, more importantly, about individual examples of where they've worked with people. So probably come back in maybe 3 quarters or so maybe not quite a year, and then we should be able to give you a much more comprehensive update.
Really helpful, thank you.
Okay, next. Any more on this one? Councillor. Oh, okay. So I'll do Councillor Heaney, and I might mark you down. So Councillor Heaney next.
Slightly confusing page numbers because the portsmouth.gov goes over the page, but it's page, I think it's 33 or 17 in the report. It's about commissioning, market shaping and partnerships, section 6.4, and it's the 4th paragraph down. I don't understand that paragraph because the first sentence says the call-off pipeline activity within the supported living framework has continued. I have no idea what that means. Could you explain?
Yeah, so apologies. So it probably should have been put slightly different looking at it. So basically, it'll be a contract that's set up, and you can just basically pull down. So whatever you need to commission, you just call off of that contract. So it's just basically saying we've carried on with our existing arrangements to actually secure supported living. So
it failed our plain English test. Apologies.
I mean, it talks about a provider being a problem. Is that because they were the go-to provider and we needed to find somebody else? Because it says it will, due to the performance concerns at another large provision, this has been prioritised within the department and the call for commence in June. So are we not able to do it because there's no one else to do it?
So I must admit, I don't know the detail around the provider, but what it's saying is basically, I think there would have been a planned order in terms of recommissioning some of the things, but due to performance of a particularly significant provider, the plan has been reprioritised so that actually the services they were providing would be recommissioned first. So that's effectively what that's saying.
Okay, yeah, I think I get it now. That's all I had on that.
Anyone else on this particular subject? No. So, Councillor, do you want to do your next question?
36 or page 20, care management system. You've obviously talked about discussing the possibility of procuring with other authorities, and obviously these are authorities outside of the existing LGR proposals in terms of the different councils. I mean, they're not all in the same group, if you know what I mean. But that was going to be my question, because clearly Hampshire County Council and they're going to be continuing their activities as a social service authority. But obviously we will be taking in some of the areas which they would be currently responsible for. So are we in a position to do anything about a care management system that brings Fair and Gospel haven't in line with us when we're procuring the system? So is there any way we can coordinate that? Because it will be important for LGR, because we don't really want those people doing a different system while we're doing another system. So
I think that there's some complexities with that, both around, you'd be unsurprised. There's some complexities both in terms of procurement, but also in terms of the legal entity and the legal responsibility. So until, my understanding, and I'm not a lawyer, until the 1st of April of 2028, those sovereign authorities exist and continue to run their business and be accountable for their business. However, we're well aware of LGR and well aware when we're started the procurement process for this new system. So what we're going to be talking to the supplier when they're chosen about is we are going to expand as a social services authority, or there will be a new social services authority. No one's expanding, there will be a new local authority. And therefore, the current number that we will be procuring for in terms of the number of people using the system will grow. I would hope by that stage we would have a reasonable estimate of the staffing. Hampshire County Council, would be able to give us a reasonable estimate of the staffing in those 3 areas, so we could give a ballpark figure. But at the moment, the intention would be that the new authority would use this relatively newly procured system, and that all of the staff working in adult social care in this new authority that needed to use the system would use that system. Sorry, it's a bit of a convoluted answer, but it's not quite straightforward.
Yeah, I mean, I've started to ask questions about the mechanisms about how we do this, because I think it's quite interesting, but also quite complicated, in that there seems to be the capacity, I would have thought, and maybe this is not a question, this is my sort of understanding of it, and is that there has to be some scope for mutual cooperation, which isn't actually about the authorities already set up, but we mutually agree among the authorities that will set up the new one that actually we can do these things. So there probably needs to be a bit of that going on, I suppose. That's what I'm concerned about, because we can't leave everything until 2028. You know, can't make a decision until 2028 because the authority's not set up or whatever, because that's bonkers.
No, I think there will be informal agreements. I mean, we're obviously subject to the election of the shadow authority after next May to be able to start making decisions and committing the new authority. So it may not happen exactly like this, but in my mind, we would be taking a plan around, here's how we think the case management system will work for the continuing Portsmouth City Council, and here's what we'd like the shadow authority to sign off on, to commit the new authority to in terms of working with staff that come in from other councils. So there should be some pragmatism, I would hope.
Graham, did you have any more on this particular issue before your next question? No.
Not on this particular issue, no.
Can I just check, Councillor Harrison, is your question on this issue?
It's about Oak Park. I just want to raise it at some point,
I'll come
whenever
back.
is appropriate.
Yeah, I'll put you on the list. Okay, so Councillor Heaney, next one.
I think I've got just one more. It really goes back to the governance report on page 24, page 40. We have this submission from the Directorate about performance, and it says that there are 2 unacceptables. There is 176 on satisfactory and 9 on good. And I'm not sure quite what's behind those. I mean, obviously, I'd be concerned about the 2 that are unacceptable, because clearly that's what it says, they're unacceptable, so they need to be changed. But when we talk about 176 being satisfactory, but only 9 at good, I would have thought that I haven't seen the background of this, that 176 satisfactory is sort of with all requirements substantively met, which means they're not all being met, and we should be aiming to get to good. So how would you comment on, is that too simplistic the way it's presented, or have we got an issue with moving to good?
So what I would say is it's a corporate reporting requirement, so probably if we were looking at it within the Directorate, it would probably appear slightly different. So, and what we obviously haven't got here is the context in terms of the other Directorates. So, so because we do what we, so this all relates to national procurement legislation that you have to publish KPIs. Because most of our stuff is under kind of like a light touch regime, because it's social care, technically we don't need to report, but we do. What I would say is we are looking at how we report, because it doesn't accurately reflect, we feel, the work that's done. So we have had some conversations with our colleagues in corporate procurement, so we're probably going to look at doing it slightly differently. So what I wouldn't want you to think is, goodness, we're commissioning things or having things that really aren't, value for money, that aren't of good enough quality. Most, I would say, are. The ones where it's unacceptable performance, I don't know the detail behind it, but what I can share with you is that we do have quite a robust contract management governance in terms of we do suspend contracts. So where we're not comfortable with the quality that we're seeing, or where we need to pause to understand, we will stop new referrals into a service. And obviously then what we'll do is we'll follow a default on performance, and then manage that. And ultimately, if the standard's not met, then obviously it could lead to termination of contract. So, please be assured that where we aren't comfortable or it's not meeting a standard, then we do have ways and means of dealing with that.
I mean, I did think it was possibly about the way in which the data is presented, because I do have occasionally sat as standing deputy on governance audit standards last year, but not for a while. So I probably missed this report when it came through. Otherwise, I'd probably asked the questions then. But thank you for that. There's just one final tiny little point, which is you're talking about ASC digital roadmap, and you're talking about using a one-year part of Magic Notes. What are Magic Notes?
It's a marvellous name, isn't it? It's a marvellous product, actually, interestingly, and we know that because our social workers like it, and social workers can be choosy about the digital technology they adopt. Essentially, it's a transcription tool. So the way it works is when we're out with a resident or carers or both in the community and making an assessment of their needs, we don't have to scribble notes because the tool is capturing via a mobile phone all of the conversation. It's then ordering the conversation, and then the social worker signs that off as an assessment. So the element of audit, if you like, is the social worker saying, yeah, that's a true and accurate record, no, that was misinterpreted. But it takes them far less time. So we went from, I can't quite remember the exact figures off the top of my head, but we went from something like a 60 to 90 minute write-up to a sort of 15 to 30 minute write-up on the system by using this tool. It was specifically designed for social workers, both working with children and working with adults. And we were challenged rightly by the organisation when we wanted to buy it, because we've got things like Copilot. We do have AI tools and we have Teams and other things that can transcribe. But the company that created this used social workers to create it, roadmap it, test it, that kind of thing. And so it's quite a intuitive tool. And so we've had overwhelming support, I think, from our practitioners for it. Saved time, enabled us to do more assessments than we would normally do if we were doing it manually. So whilst I'm cautious about saying things are a win-win, it does appear to be very popular. That's Magic Notes. Yes, please do.
Just to sort of follow on, so that's the main business benefits. The other thing is it literally falls straight into the template for the assessment, so it literally pulls into the structure, which is then shared back with the individual. And from a sort of qualitative benefit and strengths-based benefit, it actually supports the strengths-based conversations because you haven't got the piece of paper there, as Andy described, and it really means that the practitioner can have like a full conversation with the individual, and it captures it all, so there is that qualitative benefit as well.
That's really interesting and very good to hear, because I mean, I know from my own experience, if you're trying to listen to somebody talking about something complicated and be seen to be listening, but also trying to make notes is quite difficult. And if anything about my notes, when I get home and look at them 3 hours later, I can't remember some of the things I've actually written because I haven't written it very clearly. So very good. Thank you.
I've got total sympathy with that. So on my list, I've got Councillor Ashwell, and then Councillor Harrison, and then Councillor Horton. So just to let members know. So welcome back, Councillor Ashwell.
Thank you. I've actually got a follow-up from your question. So how safe is that system? How can we be sure it's safe?
Magic Notes, it's safe. The safety comes on several levels, really. We approve it with our IT colleagues, so we know that we can use it. The data is kept within this country. There's no risk under General Data Protection Regulation of it going outside the country. We've gone through the legal contracts that guarantee the security of the data. And it's not held, it's anonymised, it's not held with them as a provider. So it's our data. And then there's a deletion, again, thank you, after a month, I couldn't remember the number, after a month the recording is deleted. So those are the sorts, I mean, nothing is foolproof, of course, but as far as we know, those are the reasonable safeguards to make it safe.
Okay, thank you. Can I ask
do you want to do your next
now?
question? Yeah.
So this is going to page 14 of your report regarding occupational therapists. It's great you've managed to recruit 2 more, but do we have a start date yet? And what's the impact of them not being in post yet?
Yeah, the OT workforce it's difficult. We have a general shortage, both for our NHS colleagues and for ourselves. So that's why we celebrate when we can recruit them. But we also have a team that quite likes working in Portsmouth. We've got a very experienced principal OT who manages our team, and they're a very collegiate and strong, close team. I'll come back to you on the start dates. I don't know that detail, I'm afraid. We do manage to retain most of our OTs in Portsmouth. We've also done some, we have a grow your own kind of scheme here. So if someone starts with us as an occupational therapy assistant practitioner, OTAP, I must remember it, we then often go on to sponsor them through university to their occupational therapy training. So we're growing our own, we're bringing people in and they're staying with us over the course of their career usually. And there are then potentially promotion opportunities. We have assistant team managers, that sort of thing. But I'll come back to you with those start dates because I don't know them off the top of my head.
Any follow-up questions on that particular issue? Okay, next question to Councillor Harrison. Welcome to Holswell.
Regarding magic notes, I broke my back and had 3 months of carers visiting from St Mary's up to Waterlooville. So first of all, a lot of the time they had to spend an hour sitting in traffic on the Eastern Road, so a huge waste of time. But then they also had to write up my care plan every single day in detail. And I thought, what a waste of time and paper. Instead of just having a tick list or something, just check they'd done everything they had to do, including opening the back door and feeding my dog. You know, so anything like that to save time has got to be good, hasn't it? So, about Oak Park, I know it's a Hampshire issue, but Oak Park was a really good diagnostic centre for the people of Havant and around. I used it myself. It was such a refreshing place to be able to, A, be seen promptly, not have to wait nearly an hour, and B, pull up and park and not have to spend half an hour waiting to park, you know, being in a queue. And it was just taken away. And we don't understand why it was taken away. And because it was given to us, it was a brand new centre, it served a purpose, it was taken away. Why?
So I don't know what Oak Park is. Andy, is it, because this is, is it an adult care? Yeah, but, Councillor Horton, do you want to say something? Yeah.
I can't remember who took the questions on it, but I don't think it's Andy's area.
No, it's ICB related.
Yeah, I think it's because there were some questions last time.
Diagnostics and treatment centre, so it'd be one to ask in the next session, unless Helen.
Yeah.
So I think we've solved the mystery there. So apologies for both to Councillor Harrison and Andy as well. It's just been placed on the wrong part, so apologies for that. So we will come back to that if that's okay. So I've got next on my list Councillor Horton.
Thank you. I've got a quick question, a comment, and a request. The quick question is regarding the Liberty and Care case. Do we predict that change will have an impact on services?
Yes, inevitably. I mean, we're overturning 12 years of practice, really. It took long enough to get the Dole's practice into services, it has to be said, all services, so it will take a while to change it. I think what we've got, the positive, the thing that is in provider services' favour is there'll be far less people they need to refer. And it did become something of a tick box, I think, and that's not a criticism of anyone. It's just there was so many people were encompassed by these safeguards. And Lady Hale meant them to be safeguards. I absolutely understood her rationale at the time and now. But I think there'll be less people to refer. I think the trick for us, the key for us and for providers, health and social care, will be not throwing the baby out with the bathwater. We'll need to be really clear that the assessment changed from something known as the acid test to something called multifactorial. And so there's about 6 or 7 things that you can take account of if you're making a multifactorial assessment. We'll have to encourage and train and remind practitioners of all stripes that this is still really important, that people should not be deprived of their liberty without a legal process, which is what it is at the end of the day. So whilst there is a relief that we won't have to refer or authorise quite so many, we will still have people to whom it really applies. And essentially, if somebody's really objecting to being in an environment where they receive care or to their care, even if they're not doing that verbally, even if they're, for instance, pushing someone away who comes to give them care, we should then be saying, we think this might be a deprivation of liberty. But if someone is, to all intents and purposes, as far as we can tell, happy in their environment, happy with the care, are able to wander around the environment they're in without undue restrictions, then that wouldn't be a deprivation of liberty. So the devil is going to be in the detail, and we're going to have to be part of ensuring all of our providers understand that.
Could we have that brought back to us in future meetings as like an update? Because I'm really curious about how it will work out. Can I carry on with my other
Yeah, if you do your other question.
Yeah, so the next bit was just a bit of feedback. That on the quality of the report. I mean, I think the fact that we've had so much interest and questions is a testament to the quality of the report. And actually, the outcomes that you're working to from the strategy, I read those and I was like, yeah, wouldn't that be amazing? I mean, they're so good. So I just wanted to give some positive feedback. And my last one is more, again, a little bit of a request. It's this. What is the future of the interface between the three areas that we talk about, which is the community bed-based stuff? I brought this up at the last meeting, so you know it's something that I've got great interest in hospital discharge and then the rehabilitation service. And I know you've kind of put in the report that it's a kind of, there's a performance oversight thing, and I understand why, because there's some amazing stuff that's gone in, but I think we're still early days. So I don't have a specific question, but I suppose I have a request that we can, at a point where this performance oversight has a little bit more detail, I'd be really interested to look at the efficiencies, but also the care quality side of that. And I think it sums up the challenges that have come up in so many other questions around this interface between care and health. But as I say, I don't think I've got a specific question, but it keeps coming back to me, and I think I didn't want to let the meeting go by without actually saying that I am curious about how it is going to work out, and it would be good if we could have some more detail at a future meeting.
Yeah, happy to do that. I think we are probably, unsurprisingly, in another period of transition. We've had the Summerley unit probably for 18 months to 2 years now, I think it's been. It does provide a discharge destination for people with reablement potential, but we still are struggling with capacity for those people who may not have classical, traditional reablement potential, but still need somewhere to go from hospital, and we might be able to work with them to get them a bit more independent. It's not necessarily strict rehab. We also need to see greater capacity in our community, so more people who don't necessarily go through the hospital system are able to access rehabilitation in their own homes. And that's a capacity issue. And that's going to be writ large through LGR as well, through the new authority, whatever it looks like. So I do think there's work to do. So it is relevant and pertinent to bring back updates on that.
That's great. We'll get that picked up then for a future meeting. So I've got Councillor Beach next.
You mentioned about user involvement and finding out what they want for their services. Could you just give a short synopsis of how you get that user involvement? Is it a large pool of people? Is it a small pool? Is it mixed? What sort of impact that's having, and where that can be accessed and where it's also documented?
Interestingly, Councillor Heaney being here, it's one of the things I'm just about to prepare a short brief on for the Housing and Adult Social Care Scrutiny Committee. It happens in various ways at various places. So, for instance, we have in the City of our active Learning Disability Partnership Board, which is run by residents with learning disabilities in receipt of services and supported by professionals. We have the Portsmouth Community Autism Forum, which is chaired by a carer of somebody with autism and attended by people who identify as autistic or neurodivergent. And they help us run a service called Room 1, staffed by people with autism, working with people with autism. We do various themed pieces of co-production work. So one of the last ones we did was around extra care. So extra care being where you've got your own front door, but you've got care on site, usually in a block of some description. And we're hoping to build a new extra care facility. So we went to the people currently living in extra care and said, well, you've lived here for a while. What's good about it? What's not good about it? What mistakes did we make when we commissioned this? What things did we succeed in? And sort of gather that kind of feedback to shape the new service. We've done some senior interviews in the past 12 to 18 months where we've had a stakeholder panel. So a panel of people that access services with lived experience or carers who are part of the interview process for senior posts because they know what they want, they know what they're looking for in terms of people to lead our city. So it's a real diversity of opportunities. The place that we could do better, I think, is with some of our older people that use services, because a lot of other people will come together in natural groups or units or places or whatever that might be. But when you've got people living in a community accessing domiciliary care, for example, it's much harder to get a representative view. We do send out surveys, but then lots of people send out surveys, survey fatigue. You know, once you answer question 20, you get a bit fed up. We do have some quite good feedback. Our occupational therapists actually do, one in 10 people, they'll phone them up. And they worked with people they'd worked with to figure out what people wanted, whether they wanted a note or a phone call or whatever, and they wanted a phone call. And so we phone 1 in 10 people up and say, well, this was the service you had. What did you think of it? Could we change it? And we're starting to do that in some of our social work services. We've got a fantastic co-production group working with our residents with mental health challenges. And we're asking them to, I think we refer to them in the report, we're asking them to design our co-design strategy, if you like. So there's a real mix of things depending on how people access services. Is that helpful?
Thank you. Members, are there any more questions on adult social care? So thank you very much. We're going to note the report, and thank you, Debbie and Andy. You're welcome to stay if you want to, but we entirely understand if you need to go somewhere else and do something else. So thank you. So next item agenda is number 6. It's public health update, and we've got Helen Atkinson and Gareth Spooner. If you could come forward. Firstly, congratulations, Helen, on your award. Very well deserved. So, MBE. If you could both introduce yourselves and tell us what you do and what organisation you represent, please.
Thank you, Chair. So I'm Helen Atkinson. I'm the Director of Public Health for Portsmouth, and I'll let Gareth introduce himself.
Thank you. I'm Gareth Spooner. I'm one of the Public Health Development Managers at PCC, and I lead on tobacco control, which you'll hear a bit more about in a sec.
Great. So I don't know. So this is so this was repeated. So my notes were inaccurate earlier. So we have got also in this segment saying that you're going to provide a verbal update on the diagnostic services and haven't. Is that wrong as well? Okay. All right. So is that? Sorry. Okay. No, it's okay. Okay, so scrap that. Would you like to, we've read the reports, but if you want to give a very brief summary, please do, and we'll then ask questions.
Thank you, Chair. Now, as you know, we haven't changed the format of this report for some time, but can I just assure you the data and the updates are all updated every time we do come. I won't actually do an update on the report, and I know there's some new members, obviously, this time, but what worked really well at the last meeting is that I bought, and I probably should have asked you, but I bought Gareth for this reason, is that there's always, if there's something quite big that's changed in legislation or policy, it was quite helpful. So last meeting, I brought Alan Noble with me, who did a really, I think, thorough, because he got a lot of questions, update on substance misuse, the services, the working with the police, the combating drugs partnership. And I'm just really conscious that since we last came here, there's been quite a lot of changes around the tobacco control agenda, both obviously I'm going to use it, the ban on disposable vapes, the legislation that's come in around age of sales, which is quite a big thing, although I haven't heard that much. coverage on it, interestingly. And also, we've done a lot of work, because what is always continuously a concern is young people and vaping. And we've done quite a lot of work with the Youth Council and work around working with young people, which that Gareth can. So any of those areas, but also we continue, and Gareth leads on the Tobacco Control Alliance. We continue to work really closely with our colleagues in trading standards and the police, not only around underage sales, but also a lot around illegal tobacco and vapes. So I just wondered, I'm happy to take questions on the report, but equally, we've got Gareth, who's the expert. If there's anything on any of those areas, happy to be flexible.
Over to members. Any questions? Councillor Heaney?
A bit closer. I was a bit curious reading this. I talked about the age restriction. I must admit, I haven't looked at it in detail. But it looks like when you're 30, you're going to have to prove you were born after 2009, so therefore you won't be able to buy cigarettes. Because how is that going to work? I mean, that doesn't seem very practical.
Supposed expert, I think, with the tobacco and vapes. Yes, I mean, that's the headline, I suppose, of the measures of the tobacco and vape bill. So anyone born on the 1st of January 2009, on or after the 1st of January 2009, should never be legally old enough to be able to buy tobacco products. Obviously, that age will go up year on year. So that doesn't come into effect until next year. So we've got a bit of time to work with our licensing, our trading standards colleagues to support the retailers across the city on how that's going to be implemented. So, yeah, it's going to be a case of seeing how we go. And we're obviously a leading country in this, and we're the first nation to do it. So it's going to be really interesting to see how that does roll out. I mean, the tobacco and vapes has got lots of other measures in there as well, but that is the headline one.
In the context, which we should have said first, of course, that tobacco smoking use of tobacco is still the single greatest cause of early death and the gap in life expectancy. So put it in that context. And and positively, we've had so much legislation change over the last 20 years that we have managed to implement effectively, and we will continue to do that working with all colleagues.
I don't have a problem with the principle, because obviously the evidence is pretty clear that tobacco is, and maybe if we had thought about it a bit earlier, we wouldn't have legalised tobacco, but that brings other problems as well. But, moving from illegal to not is also problematic. I'd be interested a little bit more about this stronger enforcement powers in relation to, the regulations on vaping and stronger enforcement powers around that, because the problem we've got is that no matter the law says you can't buy these products unless you're over 18, we know lots of people do, and they access online sites and so on. So trying to enforce this is, it's another one of these sort of bolting a stable door after a horse is gone, but because I personally think we should never have made these things commercially available. We should have kept them on medical and prescription only, because we've opened up a new set of problems by doing that. But that we can't do anything about that now. We have to try and find a ways of doing that. So what are the new controls like?
Yeah, so that's probably a lot of focus of this bill as well, is around vapes and the sort of regulation around packaging, flavours, the ingredients, because it's a fine balance with vapes. So it's one of, if not the most popular method for adult smokers to help them stop smoking, and one of the most successful methods, but at the same time we don't want our young people to use them. So a part of this, the government are going to be consulting with the general population on what that should look like, because like I said, we don't want to put current vapers to go back to smoking again. So it's a fine line with that. There's another part of this is a licensing scheme. So at the minute, you don't require a license to be able to sell tobacco or nicotine products. So again, that's going to be another measure to try and help control that. And as you see in the report, our trading standards are very busy going out to a lot of the illegal retailers in the city, and these shops are being a lot more creative on how they're hiding their illegal products. So you'll see in there, they're using like cars that are parked quite a distance away from the shop to hide it. Some of them are in home addresses. So we're very reliant on intelligence from the general public. They're working very closely with the police. So Yeah, they're intelligence-led service, so they're doing as best they can with the resources they've got to try and tackle the illegal and illicit trade we've got around tobacco and vapes. But hopefully, the measures in here should give them more powers to issue like higher fines. They should be able to do more closure orders. So since this report, they've managed to close at least one shop for 6 months for breaking the law around illegal tobacco and vapes. So this will provide them with more measures to hopefully try and put off some of those criminal gangs that are doing this.
And it got front page coverage, didn't it, in the news yesterday of the closure of some of the shops.
And importantly, we have funded a post in our trading standards team in the council, because trading standards have to do an awful lot. They've got a lot of legislative powers that they have to deliver, so it's been important for us to use the funding we get from, not the Stop Smoking, I'm just careful because we're not allowed to do that, but we use our grant, the money that we get from the Department of Health and Social Care, to fund that post, which has been really important for us in the city. And also, I do think some people see it as we're being a bit mean because, if you're in, you don't have much money, what we're doing is taking away cheap alternatives. But the reality is that sales of those products are actually funding, they're funding modern slavery and quite a lot of crime, including drugs in the city. So it's a really important measure.
Graham, did you have a follow-up on this particular issue?
Not on that particular issue.
Okay, I've got Councillor Beach.
With the new legislation on the tax on vape juice, that's going to close quite a lot of vape shops. And you said the single cause of people dying is tobacco related. If they're not able to get vape products, what are you doing to stop them going back to nicotine-based cigarette? And also pushing the vape, the vape culture underground?
I think that's a really important question, because it has been a big shift for us, if I'm honest, because obviously the vape culture has been around now for some time and there's a lot of marketing. But we also know that through vape shops that there is access, and through online there is access. We're hearing actually young people vaping where there is no, what is it, the product? It's causing health problems. Yeah. So there are products that are available, not necessarily because these are illegally available, that actually do have harmful content, and I've completely forgotten what the product is. But however, so what we're doing, which I'm going to pass over to Gareth, is it's about, and as Gareth said, like everything else, we want products to be as safe as they can be and be, what's the word? You say it because I haven't got my glasses on. But basically, that you are actually buying legal products. The vaping that we are supporting, and that's obviously only for adults, not for children and young people, are products that are MHRA registered. They are within legal limits, and also there is a lot of assurance legislation to make sure that those products are safe. And we actually provide those products. So I'm now going to pass back to Gareth because that's the work that he's leading on.
Yeah, so one of the reasons why they're putting up the duty is to try and reduce the appeal to young people again. But again, it's this fine balance to try and not punish our ex-smokers who are using their products. So as part of our Stop Smoking services, we're able to provide vapes and vape juices for free to smokers. So that's one of the main measures that we're using. Sorry, my mumbly tones are not coming across. Sorry. And then we are working with our regulated and reputable local shops to try and think about how we can continue to support those who are using those shops to remain smoke free. So it's going to be an ongoing sort of process to keep doing that, basically.
Do you have any follow-ups on this? Carry on. Yeah.
What worries me is you're saying it takes children out of the question because of the price and all that, but it's also going to take quite a lot of adults out of the price who are either going to get cheaper fixes for nicotine via cigarettes, or they are going to go offline and get non-regulated vape juices, because they may not be able to get anything free because of tick boxes. You know, they may not hit certain criteria. The worry that I've got is it's just easy to go and buy a packet of cigarettes. You know, rather than try and access a GP to get a prescription for that, or, you know, go to a smoking cessation clinic to get this, or...
Don't even have to do that anymore. We make it so easy.
Yeah, I mean, from obviously this is a national decision, so obviously we're just going along with that. From what we're seeing and what we've been told, it's obviously still cheaper to be able to buy these liquids than it would be to buy a legal packet of cigarettes. So obviously it's still a lot cheaper for people to buy their vape juices and remain smoke-free. And like Helen said, that something else we're trying to do now that we're down to like our 10% sort of smoking prevalence in the city, we're trying to be a lot more creative, a lot more accessible to our much more entrenched smokers and complex sort of individuals who've got sort of multiple health conditions. So we've got the smoke-free app like we've procured, and we're able to send vapes or NRT direct to people's households without them having to leave the house or come and see the wellbeing service. So we're trying to be as accessible and as flexible as possible, but we've just got to go with what we're being told at the moment.
Any more on this issue? Councillor Standen?
Do we have a published list anywhere of the reputable vape shops and the people that we deal with?
I don't know if I have a published list as such. I can speak to our trading standards colleagues to see. We know which ones meet sort of the certain regulations and meet the certain criteria. Obviously, when the licensing scheme will come in, that will help with this massively. But I can go away and try and find that out, if that'd be helpful.
Brilliant, because I think if we managed to, I don't know, put it on the website or something like that, saying, look, these are the places to go, it's probably going to shift people into that direction, I would have thought.
Also, when will the licensing scheme come in again?
So it's out for consultation at the moment. It's probably not until 2027 at the earliest. So it's a bit away yet.
Councillor Parry, did you want to follow up? Yeah.
So it's all right, Councillor Standen, you made a really good point, but it's one of those perverse things. If you promote good practice, do we really want people doing it at all? And if we promote good practice, I don't know, I sort of have a question of caution. I'm open to be persuaded differently, but if we kind of promote the legal vape shops, I don't know. I just worry about that kind of thing.
I mean, we're always very careful with our messaging around vapes, and we're always very much in line with the CMO around the messaging on vapes. So we're obviously making sure that whenever we're saying you can access our vapes for free if you're a current adult smoker, and we recommend that as to help you stop. We never recommend young people to vape or someone to start vaping if they don't smoke. So we're sort of pretty clear with our messaging, I'd like to think. And that's generally the feedback that we get from people who've then obviously gone to access us. There's still lots of miscommunication out there from the tobacco industry, who are very good at muddying the waters. So obviously we're fighting a good battle against them. But yeah, locally we're very cautious about our messaging on how we promote vapes and stop smoking products.
Councillor Heaney next.
I mean, I see all the point that Councillor Perry is making, but I think what was being said was we were just going to say that these people meet the licensing requirements. That's not saying you should use them. It's a bit like the food hygiene ratings, right? You're rating a restaurant, just because it's got a 5-star doesn't mean we're saying, please go and use that one. We're just telling you this is what it is. And that's, I think, where we are probably on safer ground. We're just saying they meet certain conditions, and then it's up to people to decide whether they use them. And being aware of these ones, of course, is also quite useful too.
Councillor Beach, did you have a follow-up?
Yeah, it's going to be adults who can access these free services and all that. What are you going to do for the children who are addicted at this precise minute? Because are you going to make them just go cold turkey? You know, what support is going to be given to those people under 16 or 18 who already have a formed addiction and can't access this?
So our Stop Smoking Service, so the Wellbeing Service, are able to support anyone, I think it's over the age of 13, who are smokers, so we can support young people, around smoking. We can give a couple of sessions of behavioural support around vaping, mainly because there isn't any concrete evidence yet on how best to support current adult vapers to help them stop, and same with young people. So we're still waiting for evidence to suggest for people who want to stop vaping how best to support them. So we're obviously continuing to look at that. But as part of this report, you'll see in there around our youth vaping work. So last year we did a needs assessment where we spoke to 171 young people throughout the city to get their views on what we could do to help reduce the harms of vaping and smoking to them. Because we were like, right, we'll create an app for you, we'll give you all these leaflets, we'll put up a service for you to access, and not one of them said they would come to a stop vaping service. They're like, we're not going to access a app, we don't use that. So they gave us 4 clear recommendations on what they think we could do to help stop them vaping. One of which I put in there was around, they wanted us to train what they call trusted adults. So people who they said generally have an interest in their lives have got their back. So you've got in there youth providers, certain school members of staff, and we basically co-designed this training package with those individuals, and we delivered that in May. And actually the feedback was a lot better than I expected. I mean, I was expecting good feedback, but it was even better than that. So that went really well, and we're now going to look to roll that out on a more permanent basis. So these trusted adults are able to have more confidence and more information on how to support those young people. Like I say, there's still no evidence on what we can give them as such to help stop them vaping, but it's around having those conversations. And then we're really keen to explore a peer-led education programme, where again, we can't physically give a product to help them stop vaping, but what they've said is that they'd be more likely to speak to an older peer at school or from a youth setting who maybe has tried vaping, doesn't vape anymore, and how they sort of went around that journey. So that's my next task, is to try and get that off the ground, and really keen to see how that goes, basically.
You say you introduced that and you got some good feedback, but you're still waiting for evidence to see how you support. Have you not got the evidence there, and is that something that you can then publish and make it, push it out further wide, but also come up with a process which has worked, and then PDSA cycle it to make sure it's still affecting the right people at the right time, doing the right job?
I get, when we talk about evidence, that can mean several different things. So obviously this is local work around getting evidence of how those young people feel. And just so you know, we regularly do present our evidence back at competence. We did that particular work, went back to the IC, Integrated Care Partnership Assembly. But with tobacco, and including vapes, in terms of service offer, we have to meet the national and international guidance from NICE in terms of how you deliver a service. That's the evidence that we're waiting for. But it doesn't mean that we don't continue. We feed it, and that's exactly what we do. Do you know when that's? Because it's looked at continuously, so we're hopeful, because it's a really difficult message and it's a really difficult situation. We can't offer anything to young people to help them quit the nicotine, which is the addiction, because we're not allowed to give it to them. And we have to be very careful about the messaging, because what we're saying is to adults, it's actually, which is quite difficult and different for us, it's okay to vape, because vaping, if it's legal vaping, is much less harmful than smoking. But what we're saying is, but you young people, we're saying no, you can't at all. So it's a really difficult. However, the important thing is we are a very deprived city, and we are down at 10%, and that is phenomenal. I didn't think I'd see that in my career.
Councillor Harrison.
I'm always frustrated when I hear any organisation talking about stopping smoking generally, because I've been a hypnotherapist for 36 years, and hypnosis has been proved to be the best way to stop people smoking. Now, people go on courses with other people, 6 weeks, and the net result is the same as if they just went cold turkey. So I know a lot of these schemes are meant to produce results, but I really doubt whether they do. I stopped people smoking in one session, and they come back to me years later to confirm that they've still stopped. I'm obviously not the only hypnotherapist who has those sort of results. But the problem with smoking, with many other of these problems, it's not just a habit, it's a compulsive habit. So when people say, oh, but the problem is if I stop smoking, I'm going to put on weight, that is not true. Only if they have a compulsive habit, they will then have a need to keep putting things in their mouth, and that's when they put on weight. And that's why hypnotherapy deals with the problem at a deep subconscious / unconscious mind level, and that's where we get the results. So there are other ways of dealing with this problem which would actually save the NHS billions, absolutely billions, in the first level treatment and in the long-term care costs.
Helen, did you want to come in, or I've got another question, if not?
I think it's really difficult for me to answer that. I'm really sorry. So if that's okay.
Councillor Beach, did you want to ask a question?
Yeah, and holistic therapies are useful. However, they don't affect everyone and they don't work for everyone. And everyone's going to have some sort of, yes, I've worked well and it's worked well for these people, but all holistic therapies are not the same for everyone. So I think there needs to be, I get your point about the hypnotherapy working, but that might be for those who you've seen. You could do it on 100,000 people, but if you only see 10 and 10 work, that's 100% for you. The other percentage of people may not. So I think I get your point, but I think there needs to be various methods in order for that, but it's not to rule out and use hypnotherapy as a single method.
I'm not talking about all holistic therapies, and I am saying that over a period of time it has been shown that hypnosis is the most effective way to stop smoking, and that beats acupuncture, laser therapy and all sorts of other treatments. And yes, people have to want to stop, but I can tell you stories about people I've treated who didn't want to stop and they still stopped. Okay, so it doesn't work for everybody, absolutely not, but a lot of these public programs also don't work. They have the same success rate as if you just did cold turkey. I don't know what it is, but if you say 6 out of 10 or whatever it is. So there's a lot of money and time being put into programs that are really ineffective. And we could be spending that money much better as a nation. I'm not talking about Portsmouth and the local area. I'm talking about as a nation. It's really frustrating for me to hear this conversation year in, year out, knowing that we can do something much more effective.
Any more questions on tobacco vaping? Any more questions on the report at all? Helen, did you say you wanted to say something before the rest of the report, or no? Okay, Councillor Ashwell.
Thank you, Chair. I'm not sure which page it is. Sorry. Could you? Sorry, I haven't been on the committee for some years. Can you explain what LARC is, please? LARC.
That women can access LARC, as we call it, long-acting reversible contraception, and women can access from their GP. We commission GPs, but also from their sexual health service and others. So you're maybe, and I think I'm right in saying, I'm going to look at it, you can either get injections or you can also get patches. Thank you. So basically, it's a very effective option for women because it is immediately reversible if you stop having the injections and take the I've forgotten what they're called again already, patches off. Whereas obviously if you have a surgical route, that's not reversible. Yeah.
Yeah, I've got a follow-on question and now I know what that is. So in your report, you're saying the abortion rates have continued to rise in Portsmouth?
Yes.
Is there anything we're doing about that?
Oh, lots of work going on. And actually, I was going to ask at the end, what would you like me to bring next time? And I was thinking, actually, because actually what we've seen through COVID is an increase in the abortion rates, is actually to bring Hannah, who is our expert, she's both our lead for women's health, but also sexual health commissioning. So yes, the numbers, there's lots of work underway, working with primary care directly, but also working with sexual health services, working with them directly. I think it was at the last meeting that I was at with Councillor Horton. We've recently done quite a big survey with women in Portsmouth about their views, how to improve access and opportunity. And much like we have for vaping, there is much improved access for contraceptive use. It's important to mention, because is that we commission part of that, so we commission all of the contraception for choice of women who want to use contraception, but also women can access contraception because of, for instance, for medical reasons, like, you know, as you know, heavy periods, etc. So that is commissioned by the ICB of primary care. We commission for contraception, but we work very closely together. But be happy to bring Hannah, because I don't want to not give the fantastic presentation that she'll give, because she leads all of that work.
So we can take that forward for perhaps the next meeting, if that's okay.
That would be great.
Did you have any follow-ups on that while at this for this meeting? No?
No, thank you.
Okay. Got Councillor Heaney.
Yes, thank you, Chair. Page 78, the bottom there, you talk about a multi-agency warmth on prescription project, identifying patients who are high-sensitive users and suffer from cold homes. Obviously, that is an issue with the UK because, I mean, winters can be quite cold, even if not intensively cold. But I suppose it does raise the question of the rather topical issue that we're now getting much, much warmer summers, and some people will suffer, or their health will deteriorate because of the heat, and they can suffer, you know, quite seriously. I mean, obviously this is exceptional, but it's becoming more of a problem. Is there any way that people can get help for suffering from too much heat? Is there some other work being developed to help people in those situations?
But now looking to roll out, it was an innovative idea that we work very closely, obviously, in the council with people around poverty and access to support around particularly best use of energy. You know, we have the team that will go out. So we decided, and we also work very closely with our primary care colleagues and working around air quality, which I'll come back to, but mainly it was that we know the evidence is very clear on both sides that extreme weather affects health. The reality is in the cold, people with underlying respiratory problems suffer, and what we wanted to do was proactively get in and prevent. So it was working with a practice who we have worked with their texting, so that when the weather gets extreme, we send through the practice texts to individuals who've got underlying respiratory conditions, and then they can access with the details of how to get in touch with the council energy efficiency service. So we can do that. You're right, we could do the same. In fact, I have worked in an area where we have also done that in extreme heat, because in extreme heat, you not only get, because particularly those of underlying health conditions, which is why we give all of the key messaging out, stay in, shut your curtains, drink fluids, because actually our older population are more vulnerable, some very young children, those of underlying health conditions. But I have worked in another area where we also, because poor air quality also exacerbates, and when you've got extreme heat like this, it exacerbates poor air quality. So it's areas that we're talking about. Currently, we don't do that for extreme heat, but I think it's an area we will be looking at, because we've got, as you know in the report as well, we've got our air quality strategy now, and we're looking at how we can focus on health outcomes from poor air quality. And I do think heat's another area that we could do. I hope you've all seen the messaging, though, because I can tell you we've been working very hard this week through emergency planners to get all of the key messaging out today. And this room's not ideal, is it, for that?
Councillor Horton.
I know that the data's not been updated for this report, but it's a request to keep it high on the agenda, is childhood obesity, because the doubling in that primary age is and we've been focusing on it for, well, as long as I've been around, as a councillor, and it's a challenge. I don't know what the answers are, but I do notice that I'd be interested in the updated data, because I think it's annual, isn't it?
So it's an unfortunate term because it is the most up-to-date data we've got.
Yes.
Because if we had more data, we would have updated it. So unfortunately, all of that data, because it's from the National Child Measurement Programme, goes up, gets sorted and comes back to us. So it's always, some people would say out of date. It's not out of date. It's the most up-to-date data we've got. But you will be pleased to know, Councillor Horton, because we have just agreed both through the Children's Trust Board and also through the Children's Partnership Board with the Integrated Care Board, because we both have childhood obesity as a clinical priority. Well, I'm not going to say it's a clinical priority, actually, it's not. It's in the clinical priorities for the ICB, but it's actually, as you know, because you'll have seen the Foresight report, obesity is a very complex, wicked issue. It's not just what we do, it's what we all do. The reality is it's an international problem, national problem. I'm going to say it's food industry's problem, and unfortunately, we have to do what we can influence, and there's masses of work going on, as you know, working with schools, working with families. We've got and we'll do this both through working with our colleagues and as in the community with Pride of Places, that funding comes in, but we're already working. We've got a funding, because we don't get much money for it either from government, as you know. We have got some money coming through from Sport England at the moment, Southampton and Portsmouth, and it's called a partnership approach, which is it's in Paulsgrove and it's in Portsea and Lamport as well. We've got a focused programme of work working with, that's at all age, but working with families around increasing physical activity. So lots of focus, but it's a very complex issue, and unfortunately there's no silver bullet, is there? And it's a cultural society problem, but we are doing everything we can in terms of trying to shift. And what's really disappointing is actually, if you look at the data, even though it's the data we've got, which is a year out of date, it's not, whatever you say is going to sound wrong, but the data, most up-to-date data we've got, we are not seeing a huge increase at year R. What we're seeing is between year R and year 6. And we know that it's a big focus, which is why we're doing it for the Children's Trust. So we've agreed, we're working with Hayden, and we're going to renew a strategy, not a big document strategy, but a plan on the page. What can we all do together that's going to have the most impact? Because we've got to change the culture where children are not active and are eating, unfortunately, not necessarily the best foods in terms, and you know, marketing. The food industry's got a lot to answer for here. A lot of the cheapest food available to parents who have got low income is the kind of bog off, high fat food. Yeah, big issue, problem.
I just wanted to comment. I appreciate that, and the contextual information is really important. I think as a scrutiny panel that we need to make, because it is a big issue in this city, I'm not saying it isn't elsewhere. I suppose maybe if in a future meeting, are there any examples of local authorities who've had some, I'm not suggesting that suddenly they find the magic bullet, because I don't think there is, for all the reasons that you outline, but I'm just wondering, are there any examples anywhere of where there's been a demonstrable even halting of the increase in primary schools in particular, because it strikes me it is something with real investment that might change the dial a bit. But thank you for that, and I just think we need to keep raising it, because we know that a lot of the other reports that we're looking at, the numbers and the number crunching at the hospital and in adults is actually directly related to this issue, albeit a national challenge. But thank you for that update.
Could I suggest that we do bring that strategy back here? I mean, it will be going probably to the Children's Trust Board as well. But part of that strategy work will be we'll do an evidence review. I have to say, I can't think of a single place that has reduced it, but maybe I haven't looked hard enough. But because of all the reasons. But let's bring that back with the evidence review in there as well. Yeah.
We'll do that. So next question, I think, from Councillor Harrison. Do you still want to ask?
Following on from that is the offer of swimming to our residents. So I know in Portsmouth you have more pools than we do, but we have 2 public swimming pools and one of them is has a problem anyway. We don't have enough. We're currently doing a project with Sport England to assess the number of swimming pools that we need for our residents. We have, you know, deprived areas, and we have schools where the swimming pools were closed down, so the children have less opportunity to learn to swim. We've heard this week on the national news about the number of school children who cannot swim, and yet we are surrounded by water. So it's really crucial. You know, we've had children jump off a boat between Portsmouth and Gosport for fun and not be seen again, that sort of thing. So this is something we really need to look at. Now, of course, we're looking at LGR and hoping that Portsmouth are going to save us with all their swimming pools, but that might not be the case. You might already be at full capacity, but it is an issue for active wellbeing generally, how we encourage people to take part. And the cost of taking part in those facilities, it's not just how much it costs to go swimming or do a fitness class, but they're getting there and back with the £3 bus fare. And some of our residents in some of our more deprived areas now have to do 2 buses to get somewhere. So it's getting worse, not better.
Yeah, a difficult question. I mean, we are actually bucking the trend. I do know that because we've obviously got the new Lido, the old Lido's, not new Lido, the old Lido's reopened, and we've obviously got Branscombe as well. So we have got good access in a number of pools. I'm afraid I might have to go back because what we work with is any physical activity, so we're not necessarily just looking at swimming. I do recognise that is a health and safety issue in terms of children being able to swim, particularly because we're a coastal city, but I'll go back and find out. I think, because it's not my area, that we do have free swimming, do we? Councillor Horton? Yeah, sorry.
I believe we still do have free swimming at primary age, and also I think, and I can't remember where it is, but there was quite an extensive water safety strategy that was done. I think it might have been a previous scrutiny panel under education, but which talks about water safety and promoting safe swimming, etc. It was done, I want to say, a couple of years ago, but you know what happens to time. It could have been 5 years ago. There definitely was done. Yeah.
That sits under culture, regulatory services and leisure, doesn't it?
Any more questions? Any more questions from members? Okay, so thank you very much for your report. We note it. You're welcome to go, Gareth. He's on his way out already. Before we go to the next item, I just wanted to check with members. Did you want a 5-minute break to refresh yourselves? Yeah, so could we have a 5-minute break and we would restart. Can we restart at 2:45? Sorry, everyone. Okay, so thank you for the break, everyone. Welcome back. We're agenda item 7, Health and Care Portsmouth, and it's over to you again, Helen.
Thank you, Chair. And yes, I'm bringing this paper because, as I think many of you will know, I'm the chair of the Health and Care Portsmouth Partnership Board. I'm normally here with my partner and colleague Bernie, who you'll know is the, and I've got to get, because she has a new job title, who in the Integrated Care Board, she's now the Deputy Director of Partnerships for Portsmouth, works at the ICB. And
can I just, it might be really useful for new members.
Oh, yes.
Could you explain the role of Health and Care Portsmouth? That would be really helpful, I think. Thank you.
Yeah, happy to do that. So, Health and Care Portsmouth, it's actually pre me and pre Bernie, actually. I think Health and Care Portsmouth's been in place probably for about 10, 15 years now. The partnership working in Portsmouth has been very, very long-standing. It is a partnership board approach. Governance, it sits under our Portsmouth Health and Wellbeing Board, and it's where all of the partners come together. So that is the NHS, which includes the Integrated Care Board, Hampshire and Isle of Wight Integrated Care Board, the hospital, QA, what is now the Hampshire and Isle of Wight Community Foundation Healthcare Trust, as well as we have representation from primary care on our Health and Care Portsmouth Partnership Board. It's also the council in the Director of Adult Social Care, Director of Children's Services, Director of Public Health, and our Cabinet member, Councillor Winnington, is a part of that. And then we also have other partners. Obviously, Health Watch sit on there as our patient representation. We have the Hive, who represent the voluntary community sector. We also, more recently, have included the university, because obviously we now have a university with a medical school, as well as in the new, well, now really, a dental school, which we're very proud of in Portsmouth. So it's all of the partners, we come together, and this report really just is giving the 6-month update of the work. So we're not an organisation, we are a group of organisations that come together in partnership. On the paper you will see, so I won't go into the detail, but you will see we have a 5-point priority list. So I'm going to remember that. I'm going to repeat it out of memory. So our 5 priorities are children and young people. Second is improving the health of our population, our residents, and reducing health inequalities. The third is our complex adults work. And the 4th and the 5th are around adult social care, partnership working with our with the ICB, with the NHS. So one is around our Better Care Fund and how we use that combined funding, and the third one is on continuing healthcare. And what's important, because actually when you read the report, I'm sure you probably thought, well, didn't we just cover that in the previous report? The point being that this is where we bring those priorities. We've agreed the priorities together. We bring all of the work that we do together, but also the work that we're doing individually. So you'll see pieces of work that Andy will have already presented on. You'll see pieces of work that I've presented on, and I'm sure there'll be elements of that work that James might mention as well. So it's where all the partners come together, we agree priorities, and we work on them together. We have shared governance under the Health and Wellbeing Board. So I chair the Partnership Board. Andy Biddle chairs the P3 Board, which is the provider partnership approach. It is also where we deliver, importantly, the neighbourhood health work. So all of the work we've been doing over many years, working with our communities, now is part of the delivery of the neighbourhood health work, which you'll know is the big national NHS programme of work. And we work closely with the Hive, who I mentioned earlier, in terms of the community development work, which you saw in the public health presentation. So that's kind of the partnership. This report is just the last 6 months, so it's just an update on some of those key areas. And I'm going to say I'm not the expert across all of them, obviously, so I might have to bring questions back, but I'm happy to update if there's any specific asks.
Helen, could you just confirm again for new members whether it just covers the Portsmouth City area or the wider QA area, which the other sort of rest of HOSP perhaps does as well?
No, I'm afraid it does just cover the partnership in Portsmouth. So even though the hospital are part of that, the work that we do, I'm not saying there wouldn't be knock-on effects from the work across boundaries, but in the main it is just Portsmouth's work.
Thank you. Did you want to say anything about the report, or we've read it, but no? Okay.
I hope you can see there's some good progress, but that's it really.
Any members' questions on this for this particular report? No. Okay. Well, thank you. We note the report, and thanks for the explanation as well. I think it's really useful for new members to know who these bodies are. So thank you very much. So again, you're welcome to leave the meeting. I'm sure you're busy and it's probably warmer somewhere else, cooler somewhere else. So next is item agenda 8, so Hampshire and Isle of Wight ICB update. And welcome, James. Thanks for waiting. It's James Roach. Do you want to briefly just say about the organisation and your role as well?
Recognise some of the faces around the table, so congratulations to those re-elected and congratulations to those newly elected as well. It's nice to see some continuity because with other councils it's different faces, so that's good. So I'm James Roach. I'm now the Director of Neighbourhood Health for NHS Hampshire and Isle of Wight, so effectively similar role to the role you remember me on previously. I'm responsible for primary care, so that's general practice, pharmacy, optometry, dentistry, community, adult community care out of hospital, and also responsible for our partnership working with each of the local authorities. So Bernie works with me, and obviously the work that Helen's referenced in terms of the Health and Care Partnership Board, really important in terms of our joint agenda and things like neighbourhood health as well. So effectively I'm the Commissioner for those services, and I've attended this committee previously in that guise.
And I know I've trailed it now several times, but I also understand you're going to give a verbal update on the diagnostic services in Havant for Oak Park.
Oh, thank you very much.
Please tell me that's correct.
Well,
is that correct?
One expected that would be a question, so I will give an update on that as far as I can. But as members know, it is quite a contractual issue at the moment, but I will give some reassurance. Shall I?
Yeah, let's do that first because it's been well trailed.
So. If you remember, the provider has indicated a wish to change the service model at Oak Park. We're in conversations with the provider. I think the main concern from the committee, rightly, was what would happen to patients in the interim. Will services be put in place? So I think I referenced St Mary's previously and the sort of re-provision of services at Portsmouth Hospital. So in terms of the main sort of diagnostics that were traditionally undertaken at Oak Park, we have put contingencies in place. In putting those contingencies in place, clearly we've reviewed patient need and clinical need within that as well. So please be assured that there has been patient-by-patient reviews, and we have made sure that patients haven't had an undue wait or delay in terms of accessing those services. As you would expect, we are in active conversation with the contractor, and we are in contractual conversations with the contractor. And there's only so much I can say, and I'm not hiding behind commercial sensitivities, that's the reality. But what I will say is the conversations are constructive. We are exploring a number of options, and we are looking at an option appraisal in the next couple of months just to understand what the opportunities are, where the provider is at, how that aligns with our commissioning intentions as an organisation. Clearly within that, we need to consider all options, and clearly we need to think about what the long-term provision is like for patients in that area as well. I was due to meet with the MP for the area next week. I'm otherwise engaged, but our Deputy Chief Medical Officer is meeting with the MP at Oak Park with the provider and with representatives of the hospital as well. So continue to be assured that we have put contingencies in place. We do take this seriously and we are exploring all options. And that's probably all I can say at the moment, Mark.
Okay. Are you able to take questions from members on that? Yeah. So I know, Councillor Harrison, you've got a question, haven't you?
Well, it's simply that Oak Park is in the St Faith's ward on the edge of Westleigh, so Lee Park, most deprived area in Havant, and I know that there is the alternative arrangement with St Mary's, but that's not the most convenient place to get to from Lee Park, and that therein lies the problem. So
Absolutely recognise that, and I think I share the same frustration, but these things happen, and that's why it's really important we get into constructive conversations with the provider around how we take things forward.
I mean, Practice Plus are an excellent provider. I really hope that they can come up with a solution on this.
Councillor Beach.
Is it just one provider that is looking at, or is it part of a tender process, or without going through commercial sensitivity, is it they're the preferred option? It's negotiating contract to make it happen.
They're the provider in situ. They're the provider we're having conversations with, and all options are on the table. And I can't go into those options, but please be assured we're progressing discussions.
Any more questions on the diagnostic services? Members for any other questions? If you have any. Councillor Perry.
So my question's about primary care access. And I know it's going on a bit of a journey with the new e-consult. And the reason I want to raise this is I am having residents talking to me about it. So in St Jude Ward, I've got Trafalgar Medical Practice, and they announced this week that they are, their first point of access is the e-consult triage method, which is through the, well, you know what that is. And they have announced that they will help patients fill out the forms if they're having trouble with digital access and all of that. So I'm aware of that, and we know it's going through change. But my question and my worry is, I don't know if you've seen the Health Watch report that came out on their website, and they surveyed, I've written it down, they surveyed 527 residents, so it wasn't a small number, and 45% of them were aware of the access changes. So that worries me that the other 55% aren't aware of the access changes. And then also 50% of those surveyed said that they have difficulty accessing. So it's sort of twofold. We've got a cohort of our community that are digitally challenged, and then we've also got community that are also saying they're still having trouble accessing their GP. And I know things are always difficult when change is happening, but I think we need something a bit more firmer than this to understand why it's so difficult for patients.
So a couple of things. I think as the report demonstrates, across the board access is increasing. There's more demand on general practice. The point you make around online is well made. That's a national requirement. So from October 25, all practices needed to provide online consultations 10 hours a day, Monday to Friday, for non-urgent routine appointments. The rationale behind that is that effectively some of those conditions and consultations could be managed more appropriately through different means. The ethos being that in theory that would free up the GP to deal with some of the more complex cases. So we have seen more people using online routes. However, there is provision within that for anyone who has challenges accessing digital means and app accessing the system. There's still an opportunity for people to use the phone or access the surgery or have a conversation in reception. And we're really keen for any feedback where that isn't the case, because people shouldn't be disadvantaged on the basis of their ability to use digital means, and we are tracking that. Just to give you some assurance in terms of making sure that urgent needs aren't missed in all of this, what we've been able to do through this process is ensure that we've got GP-led triage at the front of this process as well. So there's a level of clinical assurance to make sure that urgent issues are picked up. This year there's a new target nationally, so practices have to ensure they see 90% of their urgent cases on the same day. So we're moving towards a mix of routine access and extending the way in which people can access general practice, and more of a focus on ensuring that urgent needs are dealt with on the day as well. So there's different models within that via the national contract that we're monitoring, but any feedback from you or your constituents around where that isn't working, we'll look into it and feedback.
Yeah, so I think we probably need to, because I had a bit of a straw poll amongst the other councillors, and they did say it's a hit and a miss. So, for example, Trafalgar have said that they will help people fill out the forms. Other practices are saying they're giving no help at all for patients to fill out the forms. And so if you could check that for us, it doesn't feel, I don't know if other councillors are aware, it doesn't feel like a consistent approach.
We'll look into that. I think the other thing we have done is we've put a lot of investment into receptionist training, the way in which appointments are sort of booked, the systems we use, the support we provide. We've got digital coordinators as well in practices. So it's the right thing to do, and we should do it. From my perspective, we're contracting practices to do it as well. So we need to make sure we address the feedback, and I'm happy to come back to this group with any updates. But I would encourage you all, if there are issues, to raise them, and we'll look into it.
Councillor Ashwell.
So, just on that note, so my practice is the Meon Health practice. I see from the chart that it's one of the bigger practices. It's got 36,000 patients. I mean, I know Whiteley's growing, the whole area is growing. I mean, they're doing well to manage, but I'm getting lots of complaints that people still can't see a doctor. And the other question is, Whiteley's still not finished being built yet. Still another 1,500 houses to be built. Is the practice going to cope?
Yeah, so we're very much aware of new developments. We inform every planning application, and the key requirement from our perspective is that any new development needs to make provision for appropriate GP services. Now, that could be a new building, an extension to an existing practice. So we ensure that developers take any change of needs into consideration, and they make provision for appropriate sort of support like general practice. I'm assuming it would be the same for schools and other public facilities to ensure that there's appropriate provision in place. So we make that point at every planning application. But we are aware of the issues in Meon. The boundary is extending, and we're putting lots of contingencies in place to address that.
So I was actually chair of North Whiteley Forum when this was discussed. And at the time, the GP surgery said they didn't want another building because they didn't want it to be empty. They would manage with the current building they have. So you're now saying that perhaps they need another building?
For some developments, there is a need that outstrips the current demand, if you like. I'm not talking about that area specifically, but there are other parts of Hampshire where we've had conversations with developers around ensuring that they make provision for a new GP practice or an extended GP practice to deal with the increased need. In some parts of Hampshire, we've seen 15,000, 20,000 new homes, and that's going to put significant pressure on public services. So we make that a requirement, if you like, in terms of that planning application.
I've got Councillor Heaney, then Councillor Harrison next.
Yes, thank you, Chair. Talking about appointments, your paragraph 5 talks about 220,000 appointments not taken up despite being booked. Is there any follow-up done to try and find out why people are actually missing appointments? I'm not saying about blaming them, but just finding out why someone will book a appointment, because it's a very large number.
So we do survey it. Health Watch has been quite helpful as well in terms of understanding the reasons why. I think we need to be really careful with this. It's not always the patient's fault, and we recognise, and this is one of the reasons why I think improved digital front ends are really important, because we need to make it easier for patients to cancel appointments as well, because some patients are fed back, they want to cancel, they can't because it takes a long time to get through. So we've got callback functionality now, we've got extended digital access, we've got extended access for patients to make it easier. Some patients will book appointments in advance, and they no longer need that appointment. There's some education around that. So it's a real mix. I mean, just to be assured that whilst that's quite a high number of do not attends, practices generally recycle that capacity for someone who needs an appointment or to do other clinical tasks. So it's not necessarily wasted time. But again, I would urge us all to have the same message to our public, that these are quite scarce appointments. They're available. You should take them up if you've booked one.
Councillor Harrison.
I've got 3 questions. To go back to Oak Park, our MP is I'm trying to be diplomatic here. He likes to get involved in certain projects and not in other ones. And this is one he has really taken on board, and he's not letting the council be involved. Now, I'm aware that the council obviously is not involved in healthcare, but we still want to be involved because it's really important to our residents. So is there any way that the councillors can be involved? Number one. Second one is about the new healthcare provision for the Newlands community. Different MP, same question, because we were involved before the MP woke up to that one. And the third one is about the increasing the number of social prescribers.
On the first two, I've met with the MP and obviously he's taken that issue very seriously. I think in all of these instances, whether it's provision of healthcare or new services, then from our perspective, we'll engage with all public representatives in that regard, and I'm very happy to keep you updated and obviously make you aware of any public meetings in that regard as well. That's the same for the Newlands issue. I think there's lots of examples of other parts of Hampshire and the Isle of Wight where councillors have been very helpful in facilitating meetings with residents. So yeah, from our perspective, we seek to involve all elected representatives in issues of mutual interest.
I'm attending Newlands Parish Council tonight, and it's always a question.
We're happy as a team, or someone from my team is happy. We'd be happy to support you with that if there's an ongoing need and an ongoing requirement for information.
Thank you.
Social prescribers?
Yeah, social.
Yeah, no, that's a good question. So primary care networks have funding to employ social prescribers. So we've seen an increase in the number of social prescribers. We continue to push that through the money that's been ring-fenced to appoint to additional roles in primary care, social prescribing being one, and they play a critical role in connecting patients to non-healthcare, broader community level voluntary sector interventions that add value. We talk about neighbourhood health in the report. That's going to be a key opportunity for neighbourhood health as well. How do we use social assets better to support people with their health and well-being, but also help them to better coordinate across public services?
Okay, I've got Councillor Beach next.
A couple of questions. The Pharmacy First initiative. I'm assuming pharmacies get funding to provide that service. But what we're seeing quite a lot of is patients going in and pharmacists, the 9 conditions that they can see, saying, I don't know about this, you need to speak to 111 because I haven't got time for this. So are we funding the Pharmacy First initiative for them to redirect patients and delay the treatment by sending them to 111?
It should be quite the opposite. It should be the opposite. So effectively, pharmacies get paid on the intervention itself. So it's in the pharmacy's interest to see more patients. It's in our interest to direct more patients to pharmacy. Often people will be redirected from 111. There may well be instances where those redirections aren't appropriate or they don't have the level of clinical information required. But more broadly, we've seen pharmacists quite accepting of the new service model and very supportive. I think you can see in the report across Hampshire and the Isle of Wight, we've seen over 250,000 people through Pharmacy First. I think that's the highest nationally. It certainly was for a few months. The best performing pharmacy in the region is just around the corner in Portsmouth. So there's lots of good examples in Portsmouth of the Pharmacy First service. There may well be instances with your example where that particular individual doesn't meet the clinical criteria or the referral's inappropriate or that need can't be dealt with at that point in time. What we've asked our GP practices and 111 to do is feedback instances where referrals to community pharmacy have not been dealt with, so we can sort of support the pharmacists to address that problem moving forward. But that's something we want to keep pushing. It's really important.
Would you like Councillor Beach to provide you with that information? Would that be useful?
Yeah, it'd be helpful if you wouldn't mind.
Is there any more questions on Pharmacy First before we go to your second question? No. So do you want to do your second question?
It's not Pharmacy First, it's pharmacy related though. I'm aware that pharmacists, if a patient turns up and they've got repeat medication issues, it can be searched for using summary care records and they can get an emergency supply. but what is being seen is, again, they're being redirected through 111 for that, because pharmacists are either doing pharmacy first or they're busy with queues out the door, and the provision of pharmacies that are open at weekends, out of hours, that sort of thing, has reduced as well. Just wondering if you can comment on that, please.
Yeah, I mean, it's the perpetual challenge, isn't it, for pharmacies? How do they balance their core business, which is dispensing, with prescribing, with access? There will be instances where they will focus more on the core business where they get income. Some good news, though. This year in the new contract, they are getting remunerated at a higher level for pharmacy first, for dispensing and for independent prescribing as well. So there's a bit more investment in the contract now to make some of these additional tasks commercially viable. I think there have been times where pharmacies have been either overrun with demand so they can't deal with everything at that point in time, or they've chosen not to lead on certain initiatives because the funding isn't there. I think we're seeing a better contractual settlement now, which means more pharmacies are in the position to provide more of the core service plus the additionality.
And is that going to be, that information going to be distributed to urgent care providers, primary care, so that they're aware? Because you see quite a lot of referrals come through 111 because they've gone to pharmacies, they can't get it, go through 111, it goes to the integrated urgent care, who then sends them back to the same pharmacy, but with a script this time.
Yeah, and that's what you're articulating is a huge missed opportunity. And actually, we need to make sure at the point of contact we can, as far as possible, give the patient what they need. So again, I'll feed that back. We do look at that, and hopefully we'll see more improvement in that area.
Did you have any more follow-ups on that? No? Okay, if you have a question later, just come back. So I've got Councillor Horton next.
I think it's the same thing I asked last time, and it is about communication, really, and I think the comments that have just been made probably highlight it. I still do worry when I talk to, like, residents that sometimes people are so confused now that they don't act, and they're likely to be, or it might be the case, that they are the people who probably should be acting, whereas other people who maybe have got more digital and social skills might be pushing things when, technically speaking, they might not be so much in need. So I suppose it's, I don't know what the answer is, other than to say I think communication needs to remain a priority, particularly with individual GPs, because it seems to me that there's no consistency across them, and I guess that's what we're aiming for here, is that equality of access.
I mean, some of this is national contract driven, so level to what is in our control. But what we did talk about with our GPs last week is we've got to accept there's an access channel that will work for a certain cohort of patients, but we still have, you know, elderly patients with more than one condition who have a level of more urgent need that could be dealt with differently. So we want to invest more in continuity of care. So that frees up the GP and the team to spend more time with those patients, put a care plan in place and help to manage their need. And again, linking back to the paper, and Helen will know, because they're, you know, local authority are involved, that's the key opportunity with neighbourhood health. We need to wrap around those type of patients more. The argument nationally is, you're right, the access-driven model may well suit our younger population who are more digitally savvy, working age. So we need to make sure we've got a mixed model. So we're keen to sort of drive continuity in a different way.
Yeah, I know there is a tendency to associate age with the digital thing, but actually I think there's something more than that as well. I think there is something about the ease or the understanding to which people can get the signposting to what they need. Actually, in the past, it was basically you rang your GP, I think. But even for those who are digitally savvy, I think maybe even approaching it, it just seems that there's too many psychological barriers to get over to actually get access to the health care that you need. So I appreciate the thing about digital access and age, but I don't think it's quite as simple as that.
Councillor Beach.
Apologies. Mental health provision, out of hours mental health provision specifically, you know, is there anything that is being looked into to increase funding towards that or provide services, because even in hours, the service provision for mental health is lacklustre sometimes. Out of hours, it's sometimes non-existent. And I know SCAS have mental health triage teams, but the provision of that is off more than it's on due to either funding or staffing. I was just wondering, as it's a big thing at the minute, especially in all ages, is there going to be more impetus put into that to increase that level of cover and service provision?
This one isn't my area, but what I can say is that there is a commitment to do more out of an institution in the community, to be more reactive. There's the programme like No Wrong Door, which is about how do you ensure people can have access at the point of crisis in the community. There's a lot of work to be done with general practice and broader community teams around identifying need and managing it appropriately. And I know there is work with the Ambulance Trust and our acute providers as well, and A&E departments, in terms of how do we streamline referral out, get access to specialist support. The other thing we're very keen on is making sure that we can support people with ongoing mental health needs in Hampshire and the Isle of Wight. And some of that's about bedded provision, but some of it's about more care at home as well. And again, going back to neighbourhood health, integrated mental health and physical health is going to be really important. And there's lots of work around what else can we do to bolster that community response. Again, Chair, happy to bring more detail back on that with others in the team if it's helpful.
Yeah, that would be helpful. So, did you have any? It's not his area, but yeah. So I've got Councillor Ashwell.
Yes, different topic. One about dentistry. So it's great. We've now got a new dental school in Portsmouth, but how long will it take those people to get trained? Is it 5 years, 7 years?
Can you use your microphone?
Sorry, about 5 years in terms of the undergraduate sort of pathway. I think the fact we've got a dental school in Portsmouth is a massive boost for dentistry. As you can see from the report, we have seen increases in access. We've got more contractors. A lot of that has required us to commission differently, pay more, work differently with sort of groups of dentists. But it's actually the ability now to sort of train local, retain local, and develop our own workforce will be critical. The one thing they do need to address nationally is so in 5 years' time, if you graduate from Portsmouth Dental School, you can go straight into private practice. If you graduate from Portsmouth Dental School and you want to go into the local NHS dentist, you have to do another year of practice. So I think that's something they need to resolve nationally, because at the end of the day, money talks. People want to get into a job. They've had 5 years of undergraduate degree under their belt. There's a lot of debt with that. So I think that's something they need to resolve nationally to make it easier for people to get into the profession.
Councillor Beach.
Just one on that. Is there a thought process to, they've done that, they've used NHS services to learn their trade. Is there a return of service that they have to go into local NHS for a certain amount of time in order to pay off their debt? Not monetary debt, but pay off their social debt to say, we've invested in you.
No, but I think just one thing linked to that is one thing we have done this year is we've paid golden hellos to dentists to work in the NHS or work in a particular area. That requires them to stay in employment in that dentist for a period of time, otherwise they have to pay that back. So I think that's the beginnings of 3 years. Yeah. So golden hello with golden handcuffs, potentially. That's what we need.
Are there any more questions from members at all on this report? Councillor Harrison.
So how do we change that system that they can go straight into a private? There's no incentive, apart from the golden hello, but how do we change that? Because I know the system was changed and that's why we lost all our NHS dentists. So how do we get it changed?
They are looking at national contractual reform, so I think that's been promised for a few years now, so hopefully we'll see that soon. You've obviously got channels by which you can make that point as well, and I'd encourage you to do so.
Thank you. Are there any more questions for members at all today? There's not. So, James, thank you very much for your report. The report is noted. The final agenda items should be very short. It's agenda item 9, dates of future meetings. So, I'm happy to have meetings on any days, but I know that Councillor Heaney, you contacted me about whether we could change the provisional dates of meetings. So we've come up with Friday the 11th of September, Friday the 27th of November, Friday the 22nd of January and Friday the 5th of March. All meetings start at 1 p.m. So I just want to formally check with the panel whether we're happy to set those as the new dates. And it's going to be obviously very difficult for always to hit everyone being able to make every meeting, but hopefully everyone here can make those meetings. Is that okay? Councillor Ashwell?
Yeah, I have to give my apologies for the next meeting.
Apologies noted, yeah.
I'll get my deputy to...
Sorry, can you repeat those dates?
Yeah, sure. They will be circulated, but it's Friday the 11th of September, Friday the 27th of November, Friday the 22nd of January and Friday the 5th of March. And all meetings start at 1 p.m. So in that case, we will change the dates of the future meetings to those. So thank you very much. So thank you, members. That's all on the agenda today. I officially close the meeting at 8. No, not 8. Just 3:27 p.m. And I'm going to ask Lisa to stop the live stream on that note of hilarious.